তাহলে আমরা এখন স্টার্ট করতে পারি?
Yes.
শুরু করেন।
Assalamu alaikum and good evening to all participants. Today in our session we have amongst us renowned electrophysiologist Dr. Rafiq Ahmed sir. I'd like to request Professor Abdul Wadir Chaudhary sir to say some words about Rafiq Ahmed sir and start our program. Wadud sir. I request
Assalamu
Professor Abdul
alaikum
Wadir
and
Chaudhary
good
sir.
evening to everybody. And this is really my pleasure to introduce Dr. Rafiq Ahmed, who is actually the founder of Electrophysiology Service of this country. He single-handedly bring all the equipments to this country, and he bring himself every year 3 or 4 times yearly to train our doctors. Today is Professor Atar, Professor Mohsin, and many others are there to serve us in the electrophysiology because of Dr. Rafiq Ahmed. We are really grateful to him as a nation, and also this is our pleasure from ECG study group. He has always been with us, and today he is going to talk about the basics of cardiac arrhythmia. We are eagerly awaiting for his lecture, so I'm not telling anymore. Sir, you can start.
Assalamu alaikum. Good morning.
Please.
Screen দেখা যাচ্ছে তো না?
Yes, sir. To submit করে দাও।
Assalamu alaikum. Good morning. একটু আমার দেরি হয়ে গেছে আজকে. We should try to start on time. So আজকে যেটা করব, we're going to do our forum is ECG forum, but I was asked to talk about arrhythmia. So I tried to blend little bit of basics. I think the understanding of basics is important. Just listening to it and remembering from time to time is important for better treatment and also for academic purpose. Always I pay homage to my homeland. Somebody was talking to me about Bangladesh, and this is our root. And I see this picture, I show this picture in all my lectures. This is where we all come from. And it doesn't matter where we are, in America, in Bangladesh, Dhaka, Rangpur, we must remember this village so that we do something for them. So this is the basic structure of the heart. It's well known. We have the conduction system with the sinus node, AV node, right bundle on the right side, and left bundle on the left side. If you look at the difference between the right and the left right bundle is a narrow structure, a single structure, and then it branches. Left bundle actually is much wider structure. It's flat, wider structure, and then it goes into left anterior fascicle and left posterior fascicle before spreading into the ventricle. And that's why the ECG is very narrow. The conduction through the Purkinje fiber is very fast. And that's why we get a QRS complex, which is about 80 milliseconds. Somebody was asking why the QRS is narrow during sinus rhythm as opposed to ventricular arrhythmia or ventricular premature beat. The premature beats go through the myocardial tissue. That's why they are very wide, and normal QRS conducts through the Purkinje fibers. Little bit of histology. The myocardium is a syncytium. That means the cells are connected to each other. And if you see, they are oriented longitudinally. So it's a very longitudinal orientation. There is no haphazard pattern in normal myocardium. And this is the histological structure. You can see that it is linear and goes along one line, which can change in pathological condition that we will come to. And this is where the cell junction, we have this intercalated disc, and that's where the electricity. The interesting thing about myocardium is that if we introduce one electrical signal in one cell, it will then activate all the cells through this intercalated disc. It is unlike skeletal muscle. Skeletal muscle, individual fibers have to be stimulated to contract. And these are different proteins that the intercalated disc binds together. And we don't have to remember all of them, but we need to remember the concept that, let's say, catenin, desmocholine, plakophilin, these are all related to some pathological processes that we see, and we are finding out more and more the genetic abnormalities involved with these proteins. And these are a list of the inherited cardiac diseases that we can see in real life, and that are related to some arrhythmia. If you look at arrhythmogenic right ventricular dysplasia here, and it is clearly related to a protein called plakoglobin abnormality. And we are talking about this cellular structure that they're longitudinally oriented. But if you look at a condition in hypertrophic cardiomyopathy, you can see these fibers now are growing. Even though the myocardium is hypertrophied, it's a bad pump because the fibers are oriented in multiple directions. And that creates an anatomical problem in contraction. Second problem, it also creates an electrical substrate for cardiac arrhythmia. We'll touch a little bit about the action potential. Multiple speakers have talked about it. I think it's important that we repeat this thing again and again to put it in our brain. Action potential, that myocardial cells outside is negative, inside is positive. And if we put an electrical stimulus, it changes, creates an action potential. Inside becomes positive, outside negative, causes cellular electrical activity, and then myocardial contraction, and then it goes back to normal pattern again during depolarization. And how does it happen? The myocardial cells, all cells are bilipid layer, and there are pores, ion channels. And you can see these are able to conduct electrolytes, and that's thereby it causes electrical activity plus contraction of the myocardium. And just conceptually, if you look at this sodium channel, you can see that there is a gate. It's resting, it is closed. And then if it is activated, the gate becomes open and it allows sodium to come in. And then immediate inactivation is done by a small temporary gate. It closes it until it goes to the final resting condition. And if you look at here, there's L, this is where the lidocaine works on the sodium channel. And this is very specific, it's important. If you look at the next slide, if you look at this calcium channel, again, resting, this is activated and then closed. If you look at the drugs, here is where the diltiazem works. This is where nifedipine works. And this is where verapamil works. So even though they are working in the same calcium channel, they are working in different locations, and it is possible that that can explain the different nature of their activity. If you look at nifedipine, it's a very good antihypertensive, but it's not an antiarrhythmic at all. On the other hand, diltiazem is a combination, which is good antihypertensive and good antiarrhythmic. Verapamil, on the other hand, is more of an antiarrhythmic than antihypertensive. So I think where these drugs are working also decides what will be their mechanism of action. So ventricular action potential, during depolarization, there is influx of sodium, and then sodium continues coming, then potassium, calcium comes in, and then potassium goes out and brings it back down to normal level. And this is on the left side, we have the action potential of the SA node. If you see, there is a clear difference. SA node action potential is a sinusoidal activity. That means it continuously works, depolarization and repolarization on its own, and that gives its automaticity. On the other hand, ventricular channel action potential is flat here until there is a stimulation here. It will not activate and produce its own action potential. But we skip through these two slides. What happens if we give drugs? If we give drugs like sodium channel blockers, there is prolongation of effective refractory period. That happens mainly because the slope of this initial part changes. So the difference is not big. However, if we use drugs like amiodarone, or which potassium channel, this causes more prolongation of the ERP. These are drugs like amiodarone, sotalol. These are potassium channel blockers. So if you look at long QT syndrome, there have been diagnosed that different locations of action of this, how it happens. Let's say long QT3, it's a function of sodium channel. There is gain in function of sodium channel. In Brugada, there is loss of sodium channel function. If you look at short QT, there is gain of potassium channel function, and long QT2, same channel, but loss of function. And if you look at like long QT1, there's a different mixtures of this loss of function. And then short QT, there is gain of function. So it can cut both ways, that if there is more action of that channel, it can cause abnormality, and perfect is long QT sodium channel. If there is a gain of function, there will be prolongation of QT condition, long QT3. If there is a loss of function, it will condition like Brugada syndrome. So what are the mechanisms of arrhythmia? Arrhythmia can happen because there is enhanced automaticity. We can have early after depolarization or late after depolarization. It can be re-entry. And there is a new mechanism, reflection. It's a little funny concept, but I think it's a form of re-entry that happens in a longitudinal fiber. So let's say I take a long piece of electric cable, the electricity can go down and then reflect back on itself and come back. And it can happen in position like Purkinje fiber or in the His bundle, you can have a deflection. It's a very difficult mechanism to prove. Now what happens? Enhanced automaticity, let's say the cell was beating at this rate, and suddenly for some reason it gets faster. And that's simple concept of enhanced automaticity. Why does it happen? So if we look at this action potential of a sinus node, you can see there is depolarization and then diastolic slope. So if the threshold changes, next bit can come early. That will be one mechanism. Second will be the diastolic potential goes higher up. It brings it earlier. And this can happen during autonomic adrenaline influx, or we can change the slope of this phase 4, and that can also cause. These are the multiple mechanisms that can cause enhanced automaticity. Now, enhanced automaticity can be physiological, like this. This is a patient with sinus tachycardia, heart rate 123. This is fairly physiological, can happen with fever, somebody becomes hypotensive, or if we start running on a treadmill or exercise, the rate will go up. That's physiological enhanced automaticity. It can be pathological also. It can be like pathological will be a supraventricular premature beat, ventricular premature beat, atrial tachycardia, and certain ventricular tachycardias can also due to enhanced automaticity. An example of this is an example that if you look at this, we have sinus rhythm, and then we have a rapid heartbeat, and I can clearly see that there is a sinus P wave, and then there is a P wave, which is driving this arrhythmia. So this is, and it's a long RP tachycardia. This is most likely an atrial tachycardia. And this is probably an automatic focus. Somebody can question me that how come it is not re-entry? One can never be 100% sure that this is not re-entry, but one mechanism that distinguishes enhanced automaticity from re-entry is that there can be some warm-up. And if you look at this P to P interval, it's about 540 milliseconds. But as we go down, it gets a little faster. And that means there is a little bit of warm-up. If we see warm-up in a tachycardia, it points towards enhanced automaticity as opposed to re-entry. And we can see that in some of the ventricular tachycardias, if we look at catecholaminergic polymorphic ventricular tachycardia, which is actually a form of enhanced automaticity, you can see there will be some change, or automatic ventricular tachycardia. There can be some acceleration of the tachycardia as it continues. But unfortunately, the problem is that in some of the reentrant tachycardia, you can also see some warm-up. So that makes it very difficult to distinguish the two. After depolarization, there can be two types. One is delayed after depolarization, which happens in phase 4, or early after depolarization, which happens in phase 2 or phase 3. And if this signal is big enough, then it can produce a signal on its own. And you can see this pattern. And as I was talking, that there can be phase 2, early after depolarization. These are calcium current dependent. Or phase 4, phase 3 is potassium dependent. Phase 4 is a totally different mechanism. It can be both calcium overload or due to sodium-potassium pump problem. And what are the arrhythmias that can happen with early after depolarization? We all know torsade that we see in long QT with drugs, or long QT arrhythmias, because in long QT syndrome, most of the time that the arrhythmia that we get will be torsade. And delayed after depolarization, arrhythmia with digitalis toxicity, like atrial tachycardia that happens in digitalis toxicity, they are delayed after depolarization. Accelerated idioventricular rhythm in acute myocardial infarction, or sometimes after angioplasty for acute MI or thrombolytics, we'll see ventricular arrhythmia, deperfusion arrhythmia. Those are actually delayed after depolarization. Some of the right ventricular outflow type tachycardia and also catecholaminergic polymorphic ventricular tachycardia, they are delayed after depolarization. And this form can actually be two types. One will be calcium overload, and the second type, which is related to catecholamines only. And those are sensitive to verapamil, calcium channel blocker, and also adenosine can terminate this VT. So we use adenosine sometimes to distinguish VT and SVT, but please remember, catecholaminergic polymorphic ventricular tachycardia can respond to verapamil. It is called verapamil sensitive ventricular tachycardia. So this is an example of torsade. We have long QT, and there is one beat, and then we have this polymorphic arrhythmia that is self-terminating. One of the questions that somebody asked me, what is the difference between VF and polymorphic ventricular tachycardia? Basically, almost similar. Most of the polymorphic ventricular tachycardia will self-terminate, but VF will not self-terminate. Re-entry is the main thing that causes majority of the arrhythmias that we see. This is a very old concept. Early 1900, it was done on a jellyfish. So let's say we take this tissue and we cut a hole in the center. So we have a strip of tissue that can conduct electricity. If I introduce an electrical signal here, it will go in both directions. And once they meet in the center, they will collide and they will extinguish because they have nowhere to go. However, let's say I put a pressure here on this strip. I introduce an electrical signal. It cannot go this way because it is blocked. It can come down this way. And by the time it comes here, if I take this block off, it can then continue round and round because there is an excitable gap ahead of it. It can continue for a period of time until this disappears, this opening disappears. And that's the mechanism of most of the tachycardia that we see in clinical practice, like AV node reentry, atrioventricular reentry, atrial flutter, and most SCAD-related ventricular tachycardia. So this barrier, now in real life, there is no hole in heart, except in atrial flutter, because in atrial flutter, there is inferior vena cava that creates a hole. So the hole that can be created can be anatomic barrier. Let's take an example. We take a ventricular myocardial, and there is an infarct in this area, and this becomes a scar. and that's an anatomic barrier, and then the electricity can go around it. Or if this is the inferior vena cava, the electricity can go around the inferior vena cava and produce a reentry circuit. There can also be functional barrier. That's a difficult concept because what happens is that electrical signal penetration can make this tissue functionally refractory, and that creates a functional barrier, and reentry can happen around it. This is a scar-related ventricular tachycardia. This is a just diagrammatic representation. The dark shades are the ones that is infarcted tissue, and these are healthy tissue that can conduct electricity. So what can happen that an electrical signal will come in, goes through this channel, and then come out. As soon as it comes out, we start seeing the electrical signal, which is the QRS complex. And then once the whole myocardium is depolarized, we become isoelectric until the next signal starts. Please remember that this signal is going through this channel, and it will produce a regular RR interval. However, for theoretical purpose, the VT is happening through this channel at a rate of 150 beats per minute. If this electricity goes through this, it will take shorter time and will come out. It can become faster, but the morphology will remain same because the exit point is same. So VT is most of the time regular, but sometimes we can see irregularity in ventricular tachycardia, mainly because of this mechanism that the exit point is same. The VT looks same, but the circuit, maybe there is a second pathway that is being used. One pathway that takes shorter time causes faster VT, one pathway that takes longer time causes slower VT, and there can be oscillation between the two. So this is the mechanism, one of the mechanisms that has been used to explain irregularity in RR interval in ventricular tachycardia. The other reentry that we see is bundle bunch reentry. These are the patients normally will present with ventricular tachycardia, which either will look like typical right bundle or typical left bundle. And most of this happen in dilated cardiomyopathy. So what can happen? That electrical signal can go down through the right bundle and produce reentry, and that produces left bundle morphology. Or if it goes the other way around, if it goes down the left bundle and comes through the right bundle backward, it will produce a tachycardia, which looks like right bundle morphology. And the treatment for this is very interesting because if you just ablate one of these pathways, you can get rid of this tachycardia. So ablation is very, very good in treating this condition as long as we have a proper diagnosis. But when we look at these tachycardias, it will be very, very difficult to differentiate between a ventricular tachycardia or SVT with underlying bundle branch block. Supraventricular tachycardia, I'm going to touch base a little bit. These are all different type of reentrant tachycardias. So this is an example of a tachycardia, that narrow QRS tachycardia, and almost invisible P wave. However, if we look carefully, there is a P wave in lead 2. And maybe in V1, there is a notch in the terminal part of the QRS complex, which is within 80 milliseconds of the QRS complex, that makes the diagnosis of AV node reentry more likely than anything else. We should never say it is 100% AV node. I will always tell people that, look, 80 to 90% of the time I'm correct, 10% time I'll be wrong. And how does it happen? There is longitudinal electrical dissociation in the AV node. One pathway conducts fast, one pathway conducts slow. So in this case, what's happening? That the electrical signal is going down through the fast pathway and producing a normal QRS. It's a long normal PR interval. However, if there is a premature beat, it can block in the fast pathway because fast pathway has longer refractory period. And then it can go down the slow pathway, producing a longer PR interval. However, it did not create an SVT. If we move forward, if now, when it comes to the bottom of the AV node, if the fast pathway is open, it can go backward. Still, it will require one more factor. it has to find this slow pathway open. And if that happens, then it can go around the AV node slow pathway and then go round and round and produce this AV node reentrant tachycardia. Interesting is that the AV node, even though we describe it as a round structure, Atahar Mohsin, they are always doing AV node ablation, AV node reentry ablation. If it were like this, really there will be high incidence of heart block. As a matter of fact, AV node is a little bit bigger structure, and the slow pathway anatomically is located somewhere here, within about a centimeter of each other. That's why we don't see that many heart block with AV node reentrant tachycardia ablation. So this is another narrow QRS tachycardia. It's a little different from the other one. If you look at it, you see that there's a P wave here, probably. And it's consistent. I can see in other leads, all the EKGs. So it looks like a RPPR is tough to say which is long, almost equal. But if we see an ECG like this, our primary diagnosis will be an atrioventricular reentrant tachycardia. And sure enough, this same patient, when patient goes into sinus rhythm, we can see this WPW syndrome, which makes the diagnosis of atrioventricular reentry more likely. But I have to caution you about one thing. The fact that somebody has WPW syndrome does not mean that that patient cannot have AV node reentry. So we have to keep an open mind about it. That's why we do when we do electrophysiology study, we need to induce the tachycardia and make sure that the arrhythmia that patient was having was atrioventricular reentry rather than an AV node reentry with bystander accessory pathway. So how does it happen? That atrioventricular reentry, an electrical signal can go down through the normal pathway and then come back through the accessory pathway and produce this reentrant circuit. It sometimes can go the other way around and also produce wide QRS supraventricular tachycardia. This is another arrhythmia that we see quite a lot. Interestingly, in Bangladesh, we don't see many atrial flutter as opposed to fibrillation. In the United States, there are a lot of cases of atrial flutter. And you can see this is a sawtooth appearance. And what happens with this arrhythmia? There is a reentry. There is an area of, so this is inferior vena cava. And on this side, I have tricuspid valve. And there is a narrow isthmus. Typical atrial flutter will always go down medially through this isthmus and come back. And that makes it easy to ablate, because if I do ablation in the atrium, the circuit will just move other way. But if there is an anatomical barrier, which is inferior vena cava and the tricuspid annulus, I can do an ablation here and cure atrial flutter. And success rate is close to 95 to 100%. But when we see this arrhythmia, we have to prove that this circuit is involved and we can map it. Interestingly, that the very interesting, I remember I went to Bangladesh many years ago and trying to explore to start EP service. And somebody told me that EP is not for us. And then I told him a story. One of my professors in 1978 said, why do we need cardiologists? We can take care of everything. And he was a respected medicine physician. And look at Bangladesh now. It was unimaginable that Bangladesh will have EP. And now Bangladesh has electrophysiology. Not only that, we have three-dimensional EP mapping in Bangladesh. I mean, technologically, Bangladesh is as good as any other developed country in the world. We can provide everything that is done. It is the question of the scope. The only limitation in Bangladesh is that we have not been able to provide it across the country yet. I think it is coming. I think I can guarantee you that before we die, we'll see that these highly complex procedures will be done all over Bangladesh, in smaller towns, Rangpur, Rajshahi, Chittagong, those places. So this is another arrhythmia that happens. It is common that in the old days, when people did atrial septal defect repair, they will cut the atrium and suture it, and that will produce a scar tissue. And then you can have an arrhythmia, atrial flutter around the scar tissue. What the surgeons do nowadays, they extend this incision line up to the IVC, because if they did it, then you don't have that opening here. And when we find this arrhythmia, we can find this arrhythmia and we can ablate in this area. So And this is three-dimension mapping of an atrial flutter. It's being done in Bangladesh now. The other part, so I'm going to stop here. I wanted to make this just a little bit shorter than normal lectures, and we are already delayed. So I'm going to stop here. Any question I'll take, or then we'll do some EKGs. Not many ECGs today. Thank you.
Sir, thank you, sir. Athar bhai, Professor Athar Ali.
Sir, other sir.
He was actually directly listening to it. So today we have amongst us Professor and Head of the Department of Medicine, Professor Zakir Hussain from Bagura, Professor Ismail Patwari from Sylhet, and as Professor Kanij Fatima, she is from Critical Care Medicine instructor. He is there, and also the cardiologist from cardiology side, Professor Mojumdar sir, Chaudhary Meshkat sir, and many others are present, sir. And also Arun Maski, Professor Arun Maski from Nepal is here, sir. So you are very correct that we need not in depth, but rather a introductory lecture to the mechanism and everything, so that the junior fellows and also those from internal medicine background can actually grasp what we are talking about.
So there are two questions in the
question. Mojumdar sir, kichu bolben?
Yes, sir.
What can I say? Thank you very much, Dr. Rafiq Ahmed Rafiq Bhai. As I have no adjectives found suitable to describe you, because you are, for the last 2 decades or more, you are constantly and consistently with us about the different meetings, workshops, and your contributions to the development of the electrophysiological services need not mention again. The one thing, the arrhythmias and the mechanism particularly is always very challenging subject to understand for me at least. It is very difficult to understand the electrophysiological aspect. Is it there is a maze operation still there in the United States for the surgeons to diminish the atrial fibrillation in the large atrium or something? Maze operation is there?
The question is whether maze operation is still done. The original surgical maze was done by cutting the atrium and suturing it. But now they have modified. What the surgeons do, if somebody is going for valve surgery and has atrial fibrillation, they will first of all clip the appendage off, and they will do radio frequency ablation of the atrium to mimic the maze, old maze procedure.
During the operation?
During open heart surgery. That adds about 10-15 minutes to the procedure.
I see.
So, yes, and it is routinely done. There are radio frequency clamps available. So what they do, they put the clamp and clamp the myocardium plus radio frequency current. And it's a pretty neat technique. And what happens, a lot of those patients will not have AFib. And if they do have AFib, subsequently we'll bring them to the lab, because what happens when you do the radio frequency ablation, the tissue can heal up. So if these patients have recurrent arrhythmia, then we can bring to the EP lab and find the gaps and ablate that area.
I see.
Thank you for a nice question.
Thank you.
Hello, sir.
My question is that understanding the mechanism is particularly important for electrophysiologists, but for the general cardiologist also from the medicine background, from treatment purpose, do we need to understand that much? Does it have that much of an impact?
It's a question, right, to me?
Yes,
I think the mechanism, understanding mechanism stimulates our brain. That's one part. And second is clearly, even for me, sometimes I will just treat patients with a medicine, and then suddenly I'll read something. It now makes sense why this is working. Why is verapamil working? And the other part is that if we don't, let's say I can become a physician for 10 years without reading books, but suddenly one day I'll find myself totally blind because during the 10-year period, medicine has progressed so much that I'm totally lost. I think that's why it's important. And there are two kinds of learning. One is active learning. I always tell people that I'm a cardiac electrophysiologist. I don't treat patients with hypercholesterolemia, but I learn from the general cardiologists. I attend their lectures and I get this passive learning so that I keep myself up. And the mechanism, I think, is very, very important to read. Thank you.
That's what also I believe, and that's why I was asking this question. But many of the fellows actually asking, do I need to understand that much? But I tell them, you may forget, it doesn't matter, but you listen to that. You have some inspiration to learn more. That's the most important part. Sir, Ismail Patwari, sir.
I'll just give an example. You don't need to know motorcycle to ride a motorcycle. But if you get stuck in the middle of somewhere and you are the only person, you need to know how to change the tires, and you will only be able to do that if you know the structure. Thank you.
Sir, Wadud
Explain bhai ki bolten?
Thank you, Professor Rafiq Ahmed, for his excellent explanation of this re-entry and other mechanism of tachycardia. I have a query. So in this era of COVID-19, what is the actual mechanism of tachycardia and other arrhythmias during this COVID infection? And how to treat this case? Even we have seen many of the cases in the post-COVID era, they also complaining of this undue tachycardia, and how to treat this case.
Yes. The question is the COVID crisis and arrhythmia. One is that, first of all, the spectrum will be the same. Second, COVID, interestingly, is a very, very multi-system disease. And one of the thing would be, first of all, if somebody has sinus tachycardia, they can be from the sickness itself. But other issue would be that we see patients with inappropriate sinus tachycardia in real life. But those are, I see 4 or 5 patients a year. Is it possible that the COVID is affecting the autonomic system in some way that is increasing that? That's a possibility. Treatment-wise, it should be same treatment as any other arrhythmia that we do. Of course, the limitation will be somebody is hypotensive and has sinus tachycardia, we cannot give beta blockers. So those are the situations that the limitations we have. Thank you.
Hello.
We are finding that during infection, some patients are presenting with inappropriate bradycardia. Then, when they are getting recovered, they are having sinus tachycardia, very inappropriate, persistent sinus tachycardia. Same patient.
Yeah. I mean, it's probably something to do with the autonomic system, autonomic imbalance.
Sir, before going to our faculties, there is we have got some distinguished panelists today. Sir, before going to them, sir, one question from me.
Yeah.
Sir, during the discussion of the arrhythmias, we always discuss about the tachyarrhythmias. Do you have anything to say about the mechanism of bradyarrhythmia, sir?
Yes. So I on purpose avoided it. There was a slide actually I removed. One is sinus bradycardia. And when I showed you the slide of autonomic enhanced automaticity, if you increase the parasympathetic tone, you can go do the reverse. That means you can take the diastolic potential down and the patient can become bradycardic. So that's one. Second will be, of course, arrhythmias, that bradyarrhythmias can happen if there is a sinus node dysfunction. Can be from fibrosis, if the sinus node can lose its function and become bradycardic or be taken over by other rhythm. Third will be if there is a problem with the conduction system. And those are anatomical problems. So if somebody has fibrosis or because of old age, the avic node gets blocked or his bundle gets blocked, you can develop complete heart block. Or patients with acute MI can acutely damage the conduction system and produce complete heart block. So those are the few mechanisms. The transient ones are autonomic tone related bradyarrhythmia. Thank you.
Thank you, sir. Sir, Professor Zakir Hussain. Hello, Zakir Hussain. Achha. Arun Maski. Do you have any comment or question, Dr. Arun Maski?
Well, this is a new field for me in arrhythmia, not my field. I'm learning from Dr. Rafik, and I've joined, and I've asked my residents, maybe I think today 10 or more from Nepal are joining. So I'm learning. I'm a panelist here. I'm learning from you a lot of arrhythmias, which I, in my practice, have missed, because most of the arrhythmias, when they come, what I do is I send to our EP fellows, they manage. So nice to learn from you, sir. And I've asked my residents to join you. So that's very good. Thank you very much for
Thank you.
giving
Thank you,
insight.
sir.
Thank you.
Sir, we were going to our panelist. One more question from me, sir. Sir, the two pathways in the AV node, that is the fast and the slow. Is it always congenital or can it be acquired, sir?
I think the question is that the slow fast pathway, I mean, these are all always there. I think you can dissociate any tissue electrically. I think that physiological property is there. If you look at that, let's forget about the AV node, the His bundle. You can electrically dissociate His bundle longitudinally. And there are proof of that. The fibers, the AV node, as I mentioned, is not a round structure. There are a lot of extension, downward extension from the AV node towards the coronary center. And that is the area that has slow conduction. The other part that you will find out that in the early days of EP, we did EP study on patients who never had SVT, and significant number showed property of dual AV nodal physiology. So these are congenital and not always necessarily pathological issue, because a lot of times it doesn't cause any pathological problem. Thank you.
Thank you, sir. Professor Mishkat Ahmed Choudhury.
Thank you, sir. It has been brilliant presentation on your part. I work in Bangabandhu Sheikh Mujib Medical University, where there we do not have the EP facilities. What happens when you're lacking some facilities, you really lag behind in the knowledge in that subject. And for the same reason, I understand so little about electrophysiology and other things. But one arrhythmia that has become prevalent nowadays, probably all over the world, one of the reasons may be that people also do have monitoring even throughout the whole year, because they have some device implanted in them, and which make them also to monitor the ECG for 1 year. And in those studies also, it has been found that atrial fibrillation is quite prevalent. And to me, it appears that probably there is a sort of epidemics within the epidemics of heart disease. We find many cases of atrial fibrillation. That was my point. And each atrial fibrillation differs from one, in regards presentation, each atrial fibrillation differs from other one. And as we understand that despite controlling the rhythm in those patients, despite the fact that we are able to convert them into the sinus rhythm, they also has to be on anticoagulant as well, if they qualify the Chadvius score. So this make a confusion among the patient and other physician, that if the patient is having antiarrhythmic drug for maintaining the sinus node, sinus rhythm, and at the same time, why he should also continue the anticoagulant. This is the thing that we have to communicate with our patient and our fellow colleagues very frequently. Other than this atrial fibrillation, other sort of arrhythmia like supraventricular tachycardia, and the arrhythmia that arises from emerging disease like Brugada syndrome and arrhythmogenic dysplasia, which we really understand so little. As a matter of fact, we understand learning Brugada syndrome and the arrhythmogenic dysplasia from our students. Actually, they are the people who first bring it in our notice that, sir, this could be Brugada and this could be arrhythmogenic right ventricular dysplasia. So it is important, sir, as you said, that the whole country should be under the network of electrophysiological study for the sake of learning electrophysiological study and the arrhythmia. Even we have been very keen in learning the electrophysiological study. I myself studied 6 books of ECG, and still ECG seems to be a Greek to me. Had we the electrophysiological facilities in the premises, possibly I would not have been that ignorant. Thank you, sir. You have been helping us a lot. We know almost you are a listen to us when the question of arrhythmia comes, and arrhythmia is such a difficult chapter to us, and so that is the reason why we remember you all the time. Thank you, sir.
Thank you, Mishkat Bhai.
Sir.
Dr. Kaniz, are you there?
Dr. Kaniz Fatima?
Yes, sir.
Kaniz, one thing I want from you, what do you, as a teacher of critical care medicine, he's an associate professor in Barden, what do you actually want from the perspective of teaching? Rafiq sir is here, the resource person is here. We want to learn not only from the cardiological point of view, but also from other subjects. Can you describe a little bit?
Thank you, sir. First, I'd like to express my gratitude to the ECG study group, especially Wadu sir and Abharaji sir, for inviting me and our critical care medicine students to participate here. And as an intensivist, I think will be benefited if different types of ECG and how to manage them in case of emergency, different type of arrhythmia, and how to manage them in case of emergency. Like in our ICU, we have to treat the patient first and then talk with the on-call cardiologist later. But first, we have to treat them first. So emergency management of different type of arrhythmias will be beneficial for all of us.
Thank you, thank you. Sir, everybody is waiting for sir's ECG session. But before that, I want to call Professor Zakir Hussain. You are here, Zakir Bhai? Professor Zakir Hussain? Sir, I think we should move to ECG presentation. There are some, our panelists will be happy to participate in the ECG discussion, I think.
Thank you. So we have, today I don't have many. We'll do few because it was my lecture day. So
Rafiq Bhai, may I have a question to you?
Sure.
I just reading an article about the use of the artificial intelligence of predicting the diastolic dysfunctions with the ECG and the clinical features without the resorting to the echocardiography. There is an article in the JAC this week. What is your idea of that? The artificial intelligence will take place in the coming few years in the interpreting and the all these things?
Well, I mean, I think the future, if you look at 3D mapping of cardiac arrhythmia, it's amazing that machine at the heart, they can look at a heart on a computer screen in 3D model. It's a totally indirect picture. I mean, the technology progression is immense. But then again, there are many other technologies that you also remember came and went. So I think this is probably just a new beginning. But it's tough to understand how just from the electrical signal, you can convert into a mechanical issue. One possibility is that if somebody can study this, you remember that there used to be 64 channel, 120 channel EKGs put all over the heart. But those recordings disappeared because practically it's impossible to do it. So whether it's going to replace echo or not, we have to wait and see. Because echo gives a direct picture, and there is 3D echo now, which gives a real-time picture of the heart.
That might be a new dimension, I think,
yes,
in the future.
In the future, yes.
In the supplementally.
Yes. Okay, so we will do a couple of ECGs. This one, my question is, what is the diagnosis and what is the mechanism of this arrhythmia? But please don't ignore the initial part of the ECG also. How much time? 30 seconds? Tushar?
30 seconds.
Tushar.
30 seconds. Maximum. So we start taking up the answers.
There are some answers already.
Yes, yes. Yes, there are answers coming.
Tushar, তোমার ওখান থেকে
Sir,
sound
10 seconds. Sir,
Yes, how
is it okay, sir?
তোমার ওখান থেকে বাজে সাউন্ড হচ্ছে একটা।
আচ্ছা 30 সেকেন্ড তো
হ্যাঁ,
Sir,
বলো
10
এখন।
seconds more. 10 seconds more, sir. 9, 8. Sir, I think we can stop taking answer and we can start discussing the
আনসার কি আসছে বলো?
the answer
sir, Atta sir.
আচ্ছা আমি বলি answer sir stop your screen share sir.
Okay. Stop করবো?
জি
না স্যার, স্টপ করবেন না। স্টপ করলে তো ইয়ে চলে যাবে তো। এটা দেখতে হবে তো।
ECG টা চলুক স্যার।
ইসি থাকবে, স্টপ শেয়ার বন্ধ করবেন না স্যার।
Okay.
আতার ভাই স্ক্রিন শেয়ারটা থাকবে, নাহলে তো ওটা না দেখতে পেলে ছেলেরা বুঝবে কি করে।
আচ্ছা okay. So sir, most of the answers are enhanced automaticity, atrial tachycardia like this. But before your final comment, can we take sir comment from our faculty sir? Hello sir.
Yeah.
Sir, before your final discussion, can we take some comment from our faculties?
Sure.
Yeah, Khalid
Khalid
Mohsin
bhai.
bhai, Professor Khalid
খালেদ
Mohsin,
ভাই।
Dr. Khalid Mohsin. Hello.
জামিল ভাই আছেন?
Dr.
এই খালেদ।
Sir,
Khalid Mohsin.
Here we can see P-wave morphologies of different types actually, yeah. And then the RP interval is also increased. So maybe it's a atrial tachycardia. Maybe my take will be multifocal atrial tachycardia.
Excellent. One more comment from Mohsin Hussain.
Sir,
হ্যাঁ, মহসিন ভাই।
জি স্যার।
Mohsin Hussain.
initial rhythm, sir, the POV is bifid. Most likely, in the most of the participants they told that it is large LA, and the rest of the part is POV is not clearly seen, but irregularly. Most likely, atrial take your terminant to atrial fibrillation. Most likely, and most likely automaticity or re-entry. Most likely the mechanism.
And you are talking about the enhanced automaticity or re-entry.
Re-entry.
Re-entry. But we can see the warm-up phenomenon. What was SARS talking? Is it
If enhance, there is no enhanced automaticity. Rest of the part most like it could be automaticity, but
sir, now your final comment, sir.
So what are the majority diagnoses?
Sir, majority diagnosis enhanced automaticity atrial tachycardia, and
Yes.
Khalid Mohsin sir added multifocal atrial tachycardia.
Yes. So I think the initial rhythm is sinus bradycardia with possible left atrial enlargement, and then it starts a tachycardia. The question is If you look at the one before the tachycardia, here is the T wave, if you can see my arrow, and then the T wave is distorted. That means there is a P wave there. And that becomes more clear as we move, we can see the P wave. P wave, I cannot see in the other lead, but in lead V1, it looks same, looking upward. So that makes the likelihood of multifocal tachycardia less rather than atrial tachycardia. Now, the question is it an atrial tachycardia or can it be an, I wish somebody would have said AV node reentry or atrioventricular reentry because I want some controversial answer. And we did not get that. But if we look at this tachycardia, first of all, there is a little bit of warm up and that suggests automaticity. Second, it is a long RP tachycardia. That means the PR is shorter than RP, which makes it more likely to be an atrial tachycardia or an atypical AV node reentry. And I think this is most likely atrial tachycardia because it starts with a P wave without any PR prolongation. So I think I agree with the diagnosis. This is atrial tachycardia, possibly automatic mechanism, and alternate diagnosis, always there should be an alternate diagnosis. Alternate diagnosis can be atypical AV node reentry.
Sir,
Thank you. Yes.
Sir, in presence of such clear P wave before the QRS,
yes,
clear P wave before QRS, should we consider AVNRT or AVRT for the differential diagnosis in this ECG?
The question is, I think there should always be a differential diagnosis. The reason there should be a differential diagnosis is that if we become too confident about ourselves, then we will misdiagnose. So I think that is the part that is important, that yes, I know it is atrial tachycardia, but I think there is always a possibility. That is the importance of differential diagnosis, either in ECG or in clinical medicine, that I just did not think of one thing. I thought of other things also. That means it tells two things, that I know atrial tachycardia, I also know other things. So I think that's why differential diagnosis is very important.
Can I ask something? Yes. From the clinical perspective, that's what the other specialties are particularly wanting to know. Okay, how are you going to treat this patient?
But it depends. So
before the treatment, sir, can I make a comment?
Sure.
A short comment, please.
Please.
This patient has got, yes. This patient has got features of left atrial enlargement, and as well as there is right axis deviation, which could imply the right ventricular hypertrophy. Also, we find that there is ST depression, which mimics a reverse T sign. So there is a possibility that possibly this patient is suffering from mitral stenosis or other things, and possibly also on digoxin. And so when we relate this arrhythmia with rest of the picture in ECG, then there is a possibility that this arrhythmia could be digoxin induced, and in that case, possibly the first diagnosis should be again the automaticity, which has induced the atrial tachycardia. Am I thinking in a proper way?
Yes.
Can I differ? The thing is that this patient has left atrial enlargement, but RVH, only the axis deviation is there, but there is no evidence of RVH. So that's more likely to be left posterior hemiplegia. And that means that could be related to increased LVEDP and perhaps enlarged LF because of that. And the T changes are actually related to the ischemia, otherwise non-specific change. You cannot obviously say these T wave changes are ischemic. So these are very non-specific origin. Sir, your comment.
Basically, there is ST depression in all the leads, and it mimics the reverse T sign.
ST depression, I would say. Look at the TP interthalant ST segment. ST segment depression, there is a clear-cut margin for that. At least there should be this level of depression that you can say that this is important. Otherwise, we should rather stay on the diagnosis of non-specific ST2F changes before committing to one way or other.
Again, I have controversy on other point. Just simple right axis deviation may indicate right ventricular hypertrophy. single most important feature can clarify right ventricular hypertrophy, because it is more common to have RVH rather than to have the left posterior heavy block, especially in the context when we have got the features of the left atrial enlargement.
So I think, unfortunately, most of my ECGs, I write down the age and clinical content. I don't have it, but there is definitely diet axis deviation. And a lot of patients with COPD can have right ventricular strain without having proper hypertrophy. And that can also, so that fits in with Professor Chowdhury's analysis. And of course, there is some ST depression, so we'll have to look at the background. The question is what to do with this arrhythmia. The treatment depends on the symptom. I mean, most of these cases, COPD patients are short runs of atrial tachycardia. When we monitor them, they don't even know. If there is no clinical symptom, we should not get carried away treating these patients. Second would be, if we have to treat this automatic arrhythmia, they respond very well to calcium channel blocker. And most of our older patients have hypertension. So if I give drugs like diltiazem or verapamil, then you can use it in patients with COPD because it doesn't do anything to the lungs. So it helps in both conditions. Thank you. Unless there is any other comment, I'm going to move to that.
Sir, I have got one question, sir. Yeah. Since there is little dispute, although very little, about the morphology of the P wave, whether this is unifocal or multifocal, and and our old teaching is that we could use the transesophageal electrocardiogram, which is also known as non-invasive electrophysiology, to see the P wave. Had we been this facility, then could we make that this patient would also be a candidate for transesophageal electrocardiography to resolve the whole issue?
Yeah, sure. I mean, it's a possibility, but with transesophageal ECG, we used to do it in the past. We have not done it for a long time, and it's a cumbersome thing to do. Most of the places do not even have the facility. But putting a transesophageal probe will not help us in diagnosing whether it's multifocal or not, because a transesophageal single electrode will not tell us much about the morphology of it. But the P wave should be. I mean, if we could see multiple other leads, and if this V1 showed multiple different morphology, then we could have said clearly multifocal. So this looks very close. But if you look at clinically, it doesn't make any difference whether it's multifocal. If I'm contemplating ablation, then it is important for me to know whether there is a single morphology or multiple morphology. Because if it is multiple morphology atrial tachycardia, that is tough to ablate. But if it is single focus atrial tachycardia in multiple ECG, then ablation is a choice. So thank you. We'll go to the next ECG.
Next ECG, sir.
So this is again bringing back that slide, that automaticity, that we can have automaticity for different reason, changing in the threshold or maximum diastolic potential or increased slope of the depolarization. Please remember there is a drug, ivabradine. It works in phase 4 of the action potential of the sinus node. And that's how ivabradine causes sinus rate slowing. So if we have patients with inappropriate sinus tachycardia, ivabradine can be used to decrease the slope of phase 4 depolarization, and that's by slowing the heart rate down. This I think everybody will know. I'm going to skip because we're running short. So this arrhythmia, this is very common. I am showing common things all the time so that we can identify them and not miss them.
Hello. Sir.
Tushar, focus on the answers.
Sir. We get 10 seconds more for the ECG. I think it's been discussed earlier a bit. Yes, sir, answers are coming. Yes, majority are in the right direction, I guess, sir.
Yeah, two questions, same, that is the polymorphic and torsion.
Yes, sir. 5 seconds more, and then we stop taking answer and start discussing.
Now, before SARS comment, we want to go to some one or more just faculties.
Yes, sir. I think, sir, we start discussing the ECG now.
I want to request MG Azam. Professor MG Azam. Shahabuddin, Professor Shahabuddin, Mohammad Shahabuddin, Silet.
Shahabuddin Bhai, will you answer?
Any comments about this ECG, Professor Shahabuddin Bhai? Acha. I want to request Shahabuddin, Professor Mohammad Shahabuddin.
স্যার আমার কাছে এটা পলিমরফিক ভিটি টর্সার ডিসপয়েন্টিসের মতোই মনে হইতেছে স্যার।
আচ্ছা, যে কোনো একটার বেছে নিতে বললে কোনটা নেবেন? এনিওয়ান?
কোনটাই চাই না স্যার।
50-50 কোনটাই চাই না। আচ্ছা 50-50 আচ্ছা I think it's a right person to শুনলাম মোহাম্মদুল্লাহ ফিরোজ।
Sir, thank you, sir. In the upper strip, the initial part shows there is sinus bradycardia with prolonged QT interval around 600 milliseconds, and the mid part shows tachycardia, wide complex tachycardia. To me, it's a polymorphic VT. So prolonged QT with polymorphic VT, that is dorsal spontis. But in the lower panel, the sinus rhythm, there is PR interval looks like variable. First beat and third beat. In between, there is a ventricular complex, ectopic. And in the middle part, there is polymorphic VT again.
We have got another expert on VT, Govindo Pal.
Atar bhai.
Thank you, sir.
Oh, Khalid Mohsin bhai, please.
Is there any in the upper strip? Is there any ROT phenomena?
Sorry.
ROT phenomena.
ROT phenomena in both the strips.
Yeah.
Yes, ROT is there. Yes.
First and upper and lower both strips there is ROT phenomenon.
So Jamil, what will be the final diagnosis and what is the mechanism? Sir, want to know that is the diagnosis and the mechanism.
It's most likely prolonged QT interval.
No. Automaticity, early after depolarization, re-entry. What mechanism you want like to choose?
Early after depolarization.
Early after depolarization.
Early after depolarization, and the diagnosis?
Polymorphic VT.
Sir, before going to Ropik sir, Mozumdar sir, do you want to make any comment, sir?
Don't ask me difficult questions. It has been discussed by the so many good ECG readers. So let Rafiq bhai tell the things straight away.
What did the audience think?
Sir, most of the audience commented.
Long QT and TDP.
Long QT.
Sir,
I think.
Sir, before going to your final comment, I have a question, sir.
Yes.
Sir, there are some terms for describing the ECG. That is twisting of the axis like this. What does it actually mean, sir?
Okay, I'm going to show that to you. So I think simple. Basically, something that looks like VF and stops. I think we should, for anybody, if we call it torsade, we will not make any mistake. VF rarely stops. If you look at the second strip, you can see that the first beat has a QT interval is about 600 milliseconds. There is a PVC, there is a pause, and there is further prolongation of the QT interval. And then there is a VT, whether we call it polymorphic, whatever. But if we look at this VT, look at the R wave here is looking up, and then it is looking down. then it is looking up. It is twisting around this. If we take একটা চিরুনি নিয়ে যদি আমরা ঘোরাইতে পারতাম তাহলে যেটা হবে it will look like that. So that's why it's called torsade de point, means it is twisting around the point. So QRS looking up and then looking down, looking up. So this is typical. The second ECG is typical, but the top one, of course, I mean, I agree with the other panelists. It looks like polymorphic VT, but clearly this is long QT associated with bradycardia and torsade. And the mechanism is early after depolarization. And most of these are phase 3, because if you look at how far the QRS is from the origin of the arrhythmia, if it were phase 2, it would be much earlier. Phase 2 is calcium current dependent. Phase 3 is potassium current dependent. And that's why, because, if we give antiarrhythmic medication, those are phase 3. I mean, these are for, as I said, theoretically, the question would be how to treat these patients. One is give magnesium. Second, keep the heart rate up. And if we don't have temporary pacemaker, we can always give isopranoline drip, or we can give dopamine or dobutamine drip to increase the heart rate. And if we increase the heart rate, it will get better, because as you can see, when it was pause was making this QT much longer. So treatment-wise, magnesium, as Dr. Kanis Fatima wanted to know, if the patient is in ICU, where the patient is going to be, we're going to give magnesium irrespective of the level of magnesium. Second, what magnesium does is stabilizes the membrane. It's same as treatment of eclampsia. Second will be to keep the heart rate up. If we can put a temporary pacemaker, that's perfect. If not, then give isopranoline, and also give or dopamine or dobutamine. Look at this QT interval, this one. This is a short RR interval. The QT is much shorter compared to other places. So that means if we can keep the rate up, the QT will get shorter. So thank you.
Sir, question is, in the second step, in the sinus rhythm, the pair interval is prolonged. Exactly. Again, there is some dissociation. It seems like the second beat, second sinus beat, and later on the last beat, the before one, there seems to be some dissociation of PUF. Is it there? Somebody was asking, is there complete heart block?
This patient was in heart block. The first ECG was not.
First one is something else. It's pair interval of shock.
Another thing, sir, I like to know R-on-T phenomena, like twisting of axis. Are here R-on-T phenomena? Exactly here, is there any
importance?
R-on-T.
Yes, R-on-T is a historical term that we use. I don't think it means much clinically, because if you look at this premature beat, yes, we see a lot of premature beat on the T wave. Not all of them induces VT-VF. I remember in the early 80s when I was doing my training, we were so much obsessed with this R-on-T phenomena. And it is similar to EP study. During EP study, we induced VT-VF with premature stimulation. And in a normal heart, we can give as premature as we want to, but we don't induce VT-VF. On the other hand, if there is a substrate for VT, we can induce VT. So yes, by term, as you said, we can call it R-on-T. But most of the PVCs, some of them are later, but majority are somewhere around that time. Yes, by definition, we'll call it R-on-T phenomena. No question about that.
Sir, one more question regarding the treatment, sir. Although it is not the today is not the topic for the treatment, but this is such a type of ECG. Sometimes many of our colleagues call us, what is the treatment? What is the role of amiodarone in this case, sir? There are somebody use amiodarone, somebody is advised that is not to use the amiodarone. What is the role of the amiodarone in this case, sir?
This is one place that I will never not use amiodarone. Yes. Because it will do two things. One, as you can see, this is bradycardia dependent and potassium current dependent block. So if we give amiodarone, this will only make the arrhythmia worse. The treatment is to keep the rate up, use magnesium if there is potassium deficiency, correct the electrolyte abnormality if there is an offending agent to avoid that. So if there is something that is prolonging QT, we should stop that drug. If we have, let's say somebody comes to the ICU and I have started erythromycin for something, and next day patient goes into the torsade. the first thing that I have to do is to stop the medicine that I started last. And on the top of that, if I then give a medicine which prolongs QT interval, like amiodarone, will make it worse. So I think everywhere, even in this country, in America, there is a reflex tendency to put people on amiodarone, but I think we have to be careful about this kind of arrhythmia.
Sir, can I ask one question, sir?
Yes.
Sir, how the torsade point is self-permitting? Is there any mechanism?
The question is, this brings into the mechanism because this is basically a form of reentrance circuit. And if you look at supraventricular tachycardia, eventually they extinguish themselves, right? Because at one point, the arrhythmia cannot continue, and there is a degree, something called wavelength phenomena. And if the certain wave, that's a little bit interesting concept, that a lot of these arrhythmias will extinguish themselves because there is no tissue preceding it to continue. Because this is not ventricular fibrillation. This is actually a reentrant circuit inside the ventricle, and it will require reflexation. And that's why.
So does it abolish the excitatory gap and tarnish the arrhythmia? The excitatory gap that is required.
What is it?
Sir, excitatory gap.
Yes, exactly.
When it stops and it diminishes the arrhythmia.
If there is no gap, the arrhythmia will stop.
Yes.
That's the part.
Sir, one of our participants asked to know, that is want to know from you, sir. Is there any role of atropine to increase the heart rate? Does it?
Oh, the question is, can I give atropine?
Right, sir.
The problem with atropine is such a short half-life that it is, we do not give atropine for this kind of condition.
Yes, sir. This is a question actually.
Yes, because atropine is a very short-acting medicine. It causes other side effects, so we try to avoid, because we need a solution that would, because this patient's heart rate is not going to go up, and I cannot keep pushing atropine every few minutes. So we have to give something that we can give as a drip, and that drip will be isoprenaline, dopamine, or dobutamine. We use dobutamine sometimes, but the best drug is isoprenaline.
Sir, is there a role of ICD for the long-term management, sir?
The question is there any role of ICD in torsade? No.
Long-term management?
No, because this is bradycardia-dependent torsade. So first line of treatment is to find the etiology of the torsade and treat it. And majority of the time it will go away. Like I have seen patients who was on amiodarone, develops complete heart block, and then develops torsade. Only thing you need to do is to put a pacemaker to treat the complete heart block. You don't need defibrillator to that patient because it was torsade.
Next is sir.
Sir, yes. I have still the confusion about the P wave, because it is the traditional teaching that you look at the P wave to solve the arrhythmia. And here in this ECG, as Professor Wadud raised the question, I cannot make anything out of P wave and its relationship with the QRS.
Yeah.
So, this complete heart block.
Yeah, I think this was high-grade AV block. This patient was initially conducted and then developed heart block, because you can see there is a PR. Now, one can argue that this conducted, but what about this one? Probably not conducted. This is probably a junctional beat. And maybe this P wave conducted, but there is probably another P wave in the middle that did not conduct. And that is probably this. So this patient was going into between complete heart block, probably some conduction. But I think this patient had a high-grade AV block.
Thank you, sir.
Next ECG, sir.
Okay, next ECG was posted on Facebook by Dr. Saif Tipu from Cox's Bazar, and one of the physicians. So I picked up this ECG, and I wanted to. So this is the ECG. The RR interval looks a little different, but please remember this was taken with a cell phone, and the QRS, the boxes are not correct. So the rate is regular. My question is, what is the arrhythmia?
Sir, I give 30 seconds for the ECG because it's a bit complicated one. So answer has started to come.
I'll give you the heart rate is 166 beats per minute.
Ten more seconds for answering.
Are all types of answers.
Okay, that's good. That I like that. That's what
Yes.
I want.
Five more seconds.
আচ্ছা প্রফেসর এমজি আজম
No.
স্যার
No.
জি স্যার স্যার শুনতে পাচ্ছি স্যার
Atar, first of all, this time I want the answer of the participants, and then I would like the faculty to support or exclude why they are not correct or incorrect.
Okay, sir, we can start discussing the ECG now.
Tell the answers.
Sir, there are many answers. Majority of the answers go in favor of ventricular tachycardia.
White complex tachycardia or ventricular tachycardia?
White complex tachycardia or ventricular tachycardia, and there are very few with SVT with aberrancy.
Okay, that's good. So now, Atar, please, you can run it. Please ask the faculty or.
Sir, the faculty, yes, sir. Actually, most of the answers are in favor of the VT. Some of the answers are VT with aberrations like this.
SVT with aberrancy, sir. There are some differences.
Sir, actually, if time permit, we could go to our participant, but time is short, so we want to directly go to Professor M.Z. Azom regarding which one you like.
Thank you, sir. এটা স্যার আমি যদি স্যার ইসিজি দিকে কেয়ারফুলি একটু দেখি মানে QRS complex wide in almost all the leads as well as ST elevation evidence in 2-3 AVF and among precordial lead গুলোতে দেখতে পাচ্ছি যে ST depression wide spread ST depression from beyond 2 to 3 4 5 6. Okay, sir, my impression it is inferior MI with wide complex tachycardia with evidence of triple vessel disease, RCA, LCX and LED triple vessel disease. আমার কাছে মনে হচ্ছে স্যার it is মানে inferior MI.
না শুনো, তুমি আগে অ্যারিথমিয়ার উপরে কমেন্ট করো, এটা ভিটি অর এসভিটি, হোয়াট উই ওয়ান্ট টু, মানে আন্ডারলাইং মানে ইসকেমিয়া বা যাই থাকুক এই দুটোর ভিতরে কোনটা?
মানে এটা আমি it is more favor in VT বলবো আর কি স্যার, wide complex tachycardia more favor in VT instead of acute myocardial infarction setting.
তাহলে আমি একটা আপত্তি জানাই, যদি আমরা ভিটি বলে থাকি প্রবাবল ডায়াগনোসিস, তাহলে আমার ইসকেমিক অরিজিন ট্রিপল ভেসেল এগুলা কোনো কিছু বলা আমরা বলতে পারি না, আমি বলা উচিত না। শুধু ইসিজি থেকে ট্রিপল ভেসেল ডিজিজ এগুলা বলা উচিত না, এটা আমরা
এটা বলা যায়,
অ্যানজিওগ্রামে ফাইন্ডিং আছে সেটা আমরা তাই বলবো, ওটা অ্যানজিওগ্রামই যথেষ্ট। কিন্তু এখানে এরিথমিয়া থাকা অবস্থায় তুমি ওইটা ওই কমেন্টটা আমরা করতে পারি না আসলে, বুঝছো না?
কোনটা এরিথমিয়া থাকা অবস্থায়
থাকি I cannot comment on that. ভিডিও অবস্থায় I cannot comment on ইসকেমিয়া।
2-3 AVF এ যদি আমি ST এলিভেশনটা দেখি, আমি 3 এর ST এলিভেশনটা অনেক বেশি দেখতে পাচ্ছি। তার সাথে আমি যদি লিড আমি যেটা 1 এ দেখতে পাচ্ছি ST ডিপ্রেশন, তার মানে হচ্ছে লিড 2-3 যদি বেশি হয় তাহলে RC ইনভলভমেন্ট আছে, আর যদি লিড 1 এ যদি ST ডিপ্রেশন থাকে তাহলে মোস্ট লাইকলি হচ্ছে RC ইনভলভমেন্ট। তার সাথে আমাকে যদি B1 B2 B3 দেখে ST ডিপ্রেশন মোস্ট লাইকলি হচ্ছে LCX, আবার যদি B4 থেকে B6 এ যদি ST ডিপ্রেশন দেখি মোস্ট লাইকলি হচ্ছে LED। তো ইট ইজ I can easily say LV dysfunction with triple vessel disease, এটা ইজিলি বলা যাবে এই সিজি থেকে।
আমি একটু বলি, the presumption is that whenever you comment about ischemic ST segment changes, the presumption is that we are talking about sinus rhythm. If it's not in sinus rhythm, those presumptions are invalid. That's the problem. When you are in VT, those presumptions are not valid. Your description is beautiful, but that's the problem.
জি স্যার আমরা মজুমদার স্যারের কথা শুনি
Rate is in favor of SVT, and it is very regular. It is in favor of SVT with the aberration conduction with the right band branch block with the aberrant conduction.
স্যার সিস্টেমেটিক অ্যানালাইসিস করলে আমাদের পার্টিসিপেন্টরা নেক্সট জানতে চাইবে ইজ দেয়ার এনি পি ওয়েভ স্যার
there is P wave possibly just after QRS. If you look very minutely to all the complex, you'll be able to find out a small P wave after QRS.
Is it one?
P wave জন্য AVL এ খুঁজলে পরে কোথায় একটু দেখা যাচ্ছে তাই না? AVL এ ভালো দেখা যাচ্ছে।
মজুমদার স্যার বলছিলেন স্যার মানে মেশকাত ভাই বললেন যে পি ওয়েভ আছে কোশ্চেন ইজ দেয়ার এনি পি ওয়েভ ইজ ইট 1:1 রিলেশন অর সামথিং এলস
P wave has
after each QRS complex there is a notch that may represent the P wave.
And also ST depression can be explained by this
no, only if you concerned with the arrhythmia, it is what Rafiq Bhai says now.
Sir, I mean the P wave that has come after QRS also has produced this ST depression. That is how the whole thing can be managed.
As discussion going on, more and more interesting answers are coming.
Okay. I want those.
Yes, sir. More part. Sir, I want to call one of our participants. What do I time permit করবে? হ্যাঁ? আচ্ছা।
permit করবে।
আচ্ছা, তারেক, বেগসিমকো তারেক, হোস্ট। হোস্ট
allow করবা কিনা?
আচ্ছা, তারেক, তুমি ডক্টর সুধীরকে অন করো তো স্ক্রিনে নিয়ে এসো ডক্টর সুধীর
স্টিলেশন আছে না 2 3 এটা স্টিলেশন হয়ে গেছে পি আছে কিউ
স্যার আমার মনে হয় যে টেক্সট বইয়ে যত অ্যানসার আছে অল অ্যানসার স্যার মানে প্রত্যেকটা অ্যানসারই আসছে স্যার
all the differential diagnosis
so this is
20 or so
স্যার সুদীশ আসছেন স্যার ইয়াতে প্যানেলিস্টে আসেন স্যার
কে আছে
সুদীশ স্যার প্যানেলিস্টে আছেন
হ্যাঁ তো দাও সুদীরকে মানে আনমিউট করো
সুদীপ স্যার আছেন
ডক্টর সুধীর
অ্যানসার করলো যে
ডক্টর সুধীর আর দেয়ার
আচ্ছা আমার মনে হয় দরকার নাই টাইম ইয়া হয়ে যাবে আমার মনে হয় যে আমরা
স্যার বলেন যে স্যার কি বলছেন
জি স্যার যেহেতু টাইম চলে যাচ্ছে জি স্যার
So I think the first thing is that it's a white QRS tachycardia with right bundle morphology. The problem is that when somebody has white QRS tachycardia with bundle branch morphology, unless it's typical, it fits into one of our like left bundle with those criteria for acute MI and the patient is having chest pain. I don't think we should get into prediction of ST segment, ischemia. It's very tough. It is very tough. But the question is, white QRS tachycardia at a rate of 166 beats per minute, the QRS duration is 160 milliseconds and a right bundle morphology. So there is one thing that is that if with right bundle white QRS, more than 140 milliseconds, it favors VT. Or left bundle over 160 milliseconds favors, I am not saying definitely, it favors VT. Second issue is there is a Q wave in lead V1 and V2, small Q wave. A small Q wave in V1 with right bundle morphology favors VT. Third is in any chest lead from the beginning of QRS complex to the deepest point of S wave, if it is more than 100 milliseconds, that favors VT. And I'm going to bring to the next ECG. Third will be, is that evidence? It is very difficult to see. We can imagine many P waves. We can imagine this is a P wave. I can imagine maybe this is a P wave. So it's tough to say if there is AV dissociation or P wave. So let's look at the next ECG. I think I thought I had this. I had the measurements. Sorry, maybe I did not save it. So I measured it actually. If you look at lead V5 from beginning of the QRS to the deep of SOA in V5 is more than 100 milliseconds. So putting all those criteria, it makes the diagnosis of a VT with the right bundle morphology. Let me.
Sir, AVL যে একটু দেখবেন AVL কি ওই যে PF কি মনে হয়?
Yeah, I mean, I looked at it.
স্যার স্ক্রিনটা একটু বড় করা যাবে স্যার? স্ক্রিনটা একটু বড় করুন।
এক সেকেন্ড আমি the current slide. Yes. Go ahead. Yes.
Sir, one or ABL কি ST depression আছে স্যার significant?
Oh, yes, there is depression. No question about that.
Sir, এখন যদি 1 থেকে যদি ABL বেশি থাকে, 1 থেকে যদি স্যার ABL বেশি থাকে, RCA যেহেতু স্যার ST elevation is more lead 3 তে যেহেতু ST elevation lead 2 থেকে বেশি, তাহলে আমাকে তো স্যার এটা আমি একটা সিদ্ধান্ত নিতেই পারি এটা স্যার। It is more
মুশকিল হলো এটা সাইনাস রিদমের জন্য এটা প্রযোজ্য, কিন্তু ওই ক্রাইটেরিয়াগুলো এটা হলো ভিটির জন্য এই ক্রাইটেরিয়াগুলো ইয়ে না তো ভ্যালিড না তো। That's the problem. You are basic জিনিসটা তো ভুল করে ফেলছো।
না স্যার, আমি যেটা বলতে চাচ্ছি আমার যে ইলেকট্রিক্যাল অ্যাক্টিভিটিটা ডিউ টু তো একটা বেসিক প্যাথোলজির জন্য হইছে একটা এমআই।
সেটা তোমার সেটা এমআই পাইয়ে সেটা কিন্তু তোমার অন্য ক্রাইটেরিয়া। এখানে যদি আমি বলতে চাই এমআই আমাকে গার্বোসা ক্রাইটেরিয়া আছে, ওগুলো আমাকে কি করতে হবে? অন্য আমি ইচ্ছা মতো বললে হবে না।
আমার ইনফিরিয়র আমার জন্য স্যার আমার মধ্যে আমার কনফিউশন হচ্ছে
বলতে পারো না। ভিটি যদি বলো ভিটিতে ইনফিরিয়র আমি ডায়াগনোস করতে পারো না। You cannot diagnose inferior MI in VT. You have to understand that. It's not sinus rhythm. The ST segment and T wave changes are not valid other than sinus rhythm.
স্যার আমি একটু বলি স্যার, কারণ ভেন্ট্রিকুলার টেকেটিভ অবস্থায় these is not from the sinus, it from the ventricle, the separate rhythm, so it is not constant, separate rhythm.
You cannot diagnose ischemia from there. Or you can understand some scar bar or MI entry MI is present by Garbosa criteria or those things. But Crabera criteria or Chaplin's criteria.
Achha, Rafiq bhai, why the small Q in the V1, V2 will suggest the ventricular tachycardia?
It's just the way it is activated. This is one of the criteria that has been shown, and I'm going to show you another ECG. I'm going to stop share and come back.
In that ECG also, there was axis deviation that also suggested actual VT. There was positive outward in AVR. AVR both were positive. The inferior lead were superior axis as a whole. 2-3 AVR were negative complexes.
Most likely, sir, fascicular VT, sir.
Fascicular VT, yes, sir.
Yeah.
Left axis deviation with RBB morphology.
As for the electrophysiologist, for us general public, we are very happy with VT only.
The axis বললেন তাই জন্য বলছি স্যার।
Yeah. RBP with inferior superior axis.
LVOT origin, sir. LVOT origin. RBP morphology.
Fascicular VT is not supposed to be rather narrow. This is 160 millisecond. Mosin?
Sir, we can differential diagnosis this is the from
the finally স্যার যতগুলো পয়েন্ট বলছে, the most of the points are in favor of the VT. That is QRS duration, RBB morphology, left axis deviation, then R2S netted interval, then AVR positive. All the points are in favor of the VT, and also the presence of the small Q in V1 and V2 also suggestive of the VT. So it is.
And Govindo, if it is LVOT origin, that means that the current will be going from up to down. Then the axis should have been towards the inferior one, but that's not here. So it's not LVOT origin.
কি হলে যে 160 হয় সেক্ষেত্রে ডিফারেনশিয়াল একটা স্যার পোস্টেরিয়র পেপিলি মাসেল ভিটি
আচ্ছা
সেক্ষেত্রে
আমার মনে আচ্ছা আমার মনে স্যার আরেকটা ইস্যু দেখাবেন স্যার
Unfortunately, I did not save it into the. It's on my desktop, but I don't know how to share it.
Can you help?
There is another criteria that you have to use in RS ratio in V5, V6. If it is less than 1, and this one fulfills all those criteria. Please remember that all the criteria that we are giving puts it most likely VT. None of these criteria will say it is 100% VT, but I have one more ECG. I have an ECG that with intracardiac recording, just to confirm, but unfortunately when I uploaded, it didn't upload into the file. So what I did, I took a similar ECG, patient who had an ICD, and I pulled up the intracardiac signals. And clearly, you can see that there is AV dissociation. So I think I wanted to show only one ECG because this is interesting, right bundle pattern ECG. I'm sorry that I don't have the other ones. I think that's the problem of rushing into things. I think we'll stop here, right?
Okay, sir. So,
how are you going to, sir, if it is posterior papillary muscle VT or whatever it is, how are you going to treat it from clinician's point of view?
One of the things, the fascicular VT, I think it's a little too wide. Initially, it looked narrow, but if you measure the interval, it's pretty wide. It's a 160 milliseconds. I don't believe that this is one of those fascicular VTs. That's number one. Number two is the treatment is, of course, standard treatment. First of all, depending on the substrate, most probably this patient has cardiomyopathy. If there is cardiomyopathy, then the treatment is simple. You need a defibrillator to prolong life, number one. And secondly, if there is recurrent ventricular tachycardia, you have to use antiarrhythmic medication. And nowadays, what we do, amiodarone, of course, can be easily used, but if somebody is 50-year-old and you are using amiodarone on the top of ICD, you are using it only to reduce number of ICD shock, not to prolong life. But then we have a lot of side effect from amiodarone. So what we try to do, if the EF is slightly on the better side, let's say 35 to 40%, we try to use drugs like sotalol. First of all, beta blocker, aggressive beta blocker. If that doesn't work, then we try to use drug like sotalol if they can tolerate. Problem of sotalol is that in patients with heart failure, they don't like sotalol. It can worsen heart failure. And if a worst case scenario, we'll use amiodarone. But then minimize the dose as much as possible. Because the goal of amiodarone is not to prolong life, it's to minimize the number of shocks. And the way I look at it, if somebody gets 1 or 2 shocks a year, that's fine. That's why you put the ICD in. But if it is getting shocks every week, every month, then it's too many. And we have to use an antiarrhythmic medication. The other thing would be that if it is always monophoric VT sent to motion or at the heart, they can do ablation of the ventricular tachycardia. And again, VT ablation is not a cure, but they can modify the substrate enough to reduce the number of shocks of the patient.
Sir, regarding beta, what type of beta blocker here? Metoprolol or bisoprolol, nebiprolol?
Well, question is what type of beta blocker? All these patients have cardiomyopathy. There are only 3 beta blockers that have been shown to be beneficial. One is carvedilol, second bisoprolol, third is metoprolol succinate, not tartrate. Even in this country, in America, a lot of cardiologists use metoprolol tartrate in heart failure patients. I don't think that is right. So metoprolol, I think for arrhythmia, metoprolol tartrate we find a little bit better. Metoprolol succinate is a little better than carvedilol or bisoprolol. But there is no proven data on that. But
thank you.
So it will be only 3 of those: metoprolol succinate, carvedilol, or bisoprolol.
Sir, আমার মনে হয় it is more than 2 hours.
আপনি স্যার এই পেশেন্টটা ম্যানেজ করলেন কিভাবে স্যার?
Oh, this is the Bangladeshi patient.
ওটা কিভাবে ম্যানেজ করলো কিভাবে স্যার?
একজন ডাক্তারের কাছে।
No, this is posted in the Facebook.
This was posted on Facebook. I downloaded it.
স্যার
And
স্যার আমার মনে হয়
I edited it.
স্যার
So
আমার
you
মনে
can
হয়
ask.
Sir, assalamu alaikum, sir.
Yes,
Sir,
Pratham.
Sir,
I think
it's me,
we-
Sudhir, sir. Sir, assalamu alaikum. Sir, আমার একটা সিম্পল কোশ্চেন ছিল স্যার, যদি আপনাকে আমাকে পারমিট করেন স্যার। আমি আনমিউট করতে পারতেছিলাম না।
তোমাকে
স্যার,
খুঁজছিলাম, হ্যাঁ।
আমি আনমিউট করতে পারতেছিলাম, আমার মাউস হ্যাং হয়ে গেছিল।
বলো
স্যার, আমার কোশ্চেন রফিক স্যারের কাছে, আমি মানে বইয়ে পড়েছিলাম that right bundle branch is the direct continuation of the his bundle somewhere. My question is, if right bundle branch is the direct continuation of the his bundle, right bundle would have been much thicker than the left, but here we have seen that the opposite is happening. What is the reason, sir? If I'm not wrong.
So it's just you have to think of a tree. A tree goes up, there are two branches. There is a narrow branch on the right side and a bigger branch on the left side.
But right
So,
bundle,
muscle mass
right
is
bundle
much
is the
bigger on the
direct
left side.
continuation. Right bundle is the direct continuation, according to book, of his bundle.
His bundle branches into right and left.
Yes, but it says that right bundle branch is the direct continuation of the.
It just goes in the same direction. It doesn't mean anything else. It goes in the same way.
It is one branch is going directly and another branch is turning toward the left. Is it?
But that branch is much bigger because they supply much bigger area. It's supply demand. Simple.
স্যার আমার মনে হয় যে it is already more than 2 hours. তো আমার মনে হয় স্যার আমাদের আরো 5 মিনিটের মতো সময় লাগবে। তার আগে আমাদের প্যানেল মানে ফ্যাকাল্টিজ এর ভিতরে আমাদের ডিস্ট্রিবিউট কয়েকজন ফ্যাকাল্টিজ আছেন, প্রফেসর জাকির হোসেন, প্রফেসর মাহবুবুর রহমান, শাহাবুদ্দিন।
জাকির ভাই একটু কিছু বলে।
জি জি, প্রফেসর জাকির হোসেন।
Unmute please. Unmute.
Thank you, Dr. Rafiq Ahmed, for a nice presentation. And I am really grateful to Professor Abdul Wadud Chaudhary, and I'm happy to see my direct teacher, Professor Abdullah Shafi Mujumdar in Dhaka Medical College. And I am seeing many of the known faces in this screen. I am trying to understand the actual mechanism of arrhythmia, particularly re-entry phenomena, and I am somewhat recapitulating my old knowledge. And many things actually I learned today, and I think in the next classes, that is every Saturday, I will be here. এবং আমি অনেক কিছুই শিখতে পারবো এবং শেখার চেষ্টা করতেছি এবং অনেক কিছু কমপ্লিকেটেড মনে হচ্ছে আমার কাছে। যাই হোক, তারপরেও রফিক ভাইয়ের প্রেজেন্টেশন এক্সেলেন্ট এবং আমি ধন্যবাদ জানাচ্ছি এত সুন্দর একটা প্রেজেন্টেশন দেওয়ার জন্য, এবং আমি ব্যক্তিগতভাবে অনেক উপকৃত হয়েছি। ধন্যবাদ সকলকে।
আচ্ছা, প্রফেসর মাহবুবুর রহমান বাবু আছেন? আচ্ছা, জামিল কিছু বলবা?
জামিল থেকে
আমি রফিক স্যারকে ধন্যবাদ জানাই প্রথমে এরকম সুন্দর একটি প্রেজেন্টেশনের জন্য। আর প্রতিটি ইসিজি ডিসকাশন খুব ডিবেটেবল ছিল এবং যেটা খুব এনজয়েবল ছিল। লার্ন এ লট। আর কিছু বলার নেই। থ্যাংক ইউ ভেরি মাচ।
স্যার আমার মনে হয় যে আমাদের পরবর্তীতে একটা জাকির ভাই, প্রফেসর জাকির, আসলে আমার মনে হয় যে উই আর হ্যাপি যে আপনি যদি আমাদের প্রত্যেকটা সেশনে থাকেন। আমাদের আগামী দিনে একটা বড় ইসিজি শো আছে রফিক স্যারের সাথে। আমাদের ওয়াদুদ ভাই সেটা ব্যাপারে একটা অ্যানাউন্সমেন্ট দিবে আর কি, যে আমাদের পরবর্তীতে 11 তারিখে একটা বিগ ইসিজি শো আছে। আর আমাদের নেক্সট শনিবার স্যার আপনার মনে আছে তো স্যার, রফিক স্যার আগামী শনিবারও কিন্তু আপনার লেকচার অ্যাট্রিয়াল টেক অ্যারিথমিয়া।
Sure, yeah.
ওকে, আমাদের নেক্সট শনিবার দিনও কিন্তু রফিক স্যারের এই প্রোগ্রাম অ্যাট্রিয়াল টেক অ্যারিথমিয়ার উপরে নেক্সট স্যাটারডে।
আরে তুমি ওই এটা দেখাবা, পোস্টারটা দেখাবা।
আর আমাদের একটা পোস্টার আছে, একটা বড় ইসিজি প্রোগ্রাম আছে রফিক স্যারের সঙ্গেই। তো এই পোস্টারটা আমার মনে হয় তারেক দেখাও তো একটু। আর শাহাবুদ্দিন ভাই, সিলেট শাহাবুদ্দিন।
শাহ ভাই কোথায়? এই তো আছে।
আচ্ছা, শাহ ভাই ছাড়া আমাদের প্রোগ্রাম সাকসেসফুল করা মুশকিল। আপনি এইটার ব্যাপারে একটু সবাইকে বলেন, কারণ এই প্রোগ্রামটা খুব ইউজফুল হবে। মানে এই যে আমাদের 11 তারিখের প্রোগ্রাম। শাহ ভাই
তুমি পোস্টারটা দেখাও।
কি করতে হবে সেটা শুধু বলবেন, বাকিটা আমি আছি।
আপনার ফ্রেন্ডদের ভিতর শুধু একটু বলে দিবেন। ওনার প্রচুর ফ্যান।
আব্বাই ওখানে জুনিয়র ছাত্রদের মধ্যে হলো সাংঘাতিক জনপ্রিয়।
আমি দেখাচ্ছি, একটু পরে দেখাচ্ছি স্যার।
আচ্ছা
দেখিয়ে দাও।
আচ্ছা একটু পরে দেখালে আমি একটা শুধু ততক্ষণ তুমি তারেক রেডি হলে আমাকে বলো।
আমি রেডি স্যার।
তাহলে দেখাও
তাহলে শেয়ার স্ক্রিন করো। এটা ফুললি করে দাও। আতার ভাই একটু বলেন।
স্যার এটা আমাদের ইসিজি স্টাডি গ্রুপেরই আমাদের যে অনলাইন কোর্স চলছে, তার বাইরে আমাদের ইসিজি ফেস্টটা, যেটা করোনার সময়ের বাইরে আমরা দেশের বিভিন্ন জায়গায় করতে হবে। আমাদের সঙ্গে রফিক স্যার থাকতেন, আমাদের প্রফেসর শাহাবুদ্দিন অনেকেই ছিলেন। তো এই প্রোগ্রামটা যেহেতু এখন ভার্চুয়ালি হচ্ছে, সেজন্য আমাদের এরকম একটা বিগ ইসিজি শো, এবং আমি মনে করি যে এটা খুবই একটা ইন্টারেস্টিং হবে। আমরা বোথ ট্র্যাকি এবং ব্রেডি দুইটাই কভার করার চেষ্টা করি, এবং যাতে করে আমাদের টার্গেট অডিয়েন্সের মানে ইচ্ছা অনুযায়ী হয়, সেই অনুযায়ী কিন্তু প্রোগ্রামটা হবে। আমাদের ওয়ান অফ দ্য স্পিকার রফিক স্যার, এবং আরেকজন হচ্ছে ও মানে অভিষেক দেশমুখ, উনি হচ্ছে মেয়ো ক্লিনিকে আছেন। তো এই দুটাই হবে আমাদের মানে মেইন ফ্যাকাল্টিজ, এবং আমাদের এই প্রোগ্রাম হচ্ছে ফ্রাইডে। স্যার মজুমদার স্যার, মানে কিছু স্যার আপনার সঙ্গে একটু ওভারল্যাপ করবে মনে হয় স্যার।
এখানে একটু না, পুরোটাই তো ওভারল্যাপ করবে।
স্যার আমরা আসলে উনার সাথে আর টাইম মিলাতে পারছিলাম না
আমেরিকার সাথে করতে গিয়ে স্যার, এটা কিছুতেই হলো না। তো এখন
উইল ডিসকাস না, আমরা হয়তো আমাদের প্রোগ্রামটাকে একটু রিসেট করতে পারি।
স্যার দেখেন স্যার, মানে এখনই মনে পড়লো যে আসলে তো এরকম হবে এটা। তো ওই সময় একটা স্যার খুবই পপুলার আমাদের ফ্রাইডে ইকো প্রোগ্রাম হয়, তো সেটার সঙ্গে কিছুটা ওভারল্যাপ করবে। কিন্তু তারপরেও স্যার এইটা হচ্ছে আমাদের যারা পার্টিসিপেট আছে সবাইকে আমরা বলছি যে তারা যেন সবাই থেকে, এবং তারা যেন এটা সার্কুলেট করে দেয়, যাতে করে এই প্রোগ্রামটা আমাদের এই প্রোগ্রামের মাধ্যমে, যাতে করে আমি মনে করি যে এটা খুবই ইউজফুল প্রোগ্রাম হয়। ওয়াদুদ ভাই।
আতা ভাই, এটা কি শনিবার?
না, এটা
শুক্রবার।
ফ্রাইডে মর্নিং।
টাইমটা কত?
টাইমটা 10টা থেকে 12:30টা।
10টা থেকে বাংলাদেশ টাইম, 10টা থেকে 12:30টা।
সকাল 10টা।
11 সেপ্টেম্বর
সকাল 10টা।
হ্যাঁ সকাল 10টা। আর শাহ ভাই আপনার ফ্যানদের একটু বলে দিন প্লিজ।
জি, আরেকটা হলো 9:30 থেকে 12টা। এটা
ওটা
ইন্ডিয়ান টাইম।
মানে আপনি ওই সময় যদি কলকাতায় থাকেন।
এটা কয় তারিখ? 11 তারিখ না?
11 তারিখ, আগামী
11 তারিখ ফিক্স করছি। মজুমদার স্যারেরটা তাহলে ইসের পরে 3টা থেকে নিয়ে
বিকালে
না স্যার, টাইম আগে আনা যায় কেন? স্যার যদি 8টা আনতে পারে।
না টাইম আগাতে পারবেন না, ওইটা স্যার আসলে ওইটা বিকালে হলে পরে আমরা মিস করতে চাই না। ওইটা খুব ভালো প্রোগ্রাম হয়।
না আমরা ওটা ভালো প্রোগ্রাম। আমরা
হ্যাঁ দেখি, আমি একটু আমার টিমের সাথে কথা বলে দেখি ওরা কি বলে।
ফিরোজ আছে,
ফিরোজ আর মনোয়ার আছে, ওদের সাথে কথা বলে যে টাইমটা আসলে কোন দিকে নিয়ে গেলে আমাদের সুবিধা হয়।
কারণ ওইটা লেকচারগুলো খুব চমৎকার লেকচার হয়,
মানে একটু অ্যাডজাস্ট করতে হবে কি স্যার? অ্যাডজাস্ট
প্রফেসর ওয়াদুদ, তাহলে 11ই সেপ্টেম্বর সকাল 10টা।
আচ্ছা
আমি লিংক পাঠিয়ে দেব স্যার।
আচ্ছা, লিংকটা একটু আগে পাঠালে আমি এটা সার্কুলেট করব আমার ডাক্তারদের।
জি জি জি
তারেক, এটা তোমার দায়িত্ব। স্যারের এতে চলে যায় লিংক আগে, আপনি তাকে এই জানাবা আগে। শাহ ভাইয়ের কাছে, জাকির স্যারের কাছে, সবার কাছে আগে চলে যায়। ইসমাইল স্যারের কাছে, ইসমাইল পাটোয়ারি স্যারের কাছে।
So Wadud, there will be a lot of our residents would be joining too.
Yeah, please. It will be also going to you.
তারেক, তুমি স্ক্রিন শেয়ারটা বন্ধ করো তারেক।
জি স্যার।
আপনি ওই যে ইসিটা দেখাই দেন।
আমি আচ্ছা, এটা হচ্ছে আমাদের ফাইনাল, আমাদের লাস্ট পার্ট স্যার। আমাদের মনে হয় যে এই ইসিটা স্যার ফেসবুকে পোস্ট করা ছিল। রফিক স্যারকে বলেছি স্যার আপনাকে আমি কিন্তু যে ফেসবুকে ইনভাইট করছি, এরপরে আমি আরেকটু আপডেট করলে আপনিও স্যার এটা দেখতে পারবেন নাকি। তো এইটা আমাদের ইসিজি অফ দ্য উইকে ফেসবুকে এটা আপলোড করা ছিল, এবং আমার মনে হয় যে কনগ্রাচুলেশন টু প্রফেসর আব্দুল ওয়াদুদ, মোস্ট অফ দ্য পার্টিসিপেন্ট কারেক্টলি অ্যান্সার যে এটা হচ্ছে ওয়াইলেন সিনড্রোম। মোস্ট অফ দ্য পার্টিসিপেন্ট, আমার মনে হয় একজনও মিস করে নাই, এবং এটা আমাদের প্রফেসর ওয়াদুদের গত লেকচারে এটা ছিল। তো ওয়াদুদ ভাই আপনি এটার উপর বলেন।
এটা ওই যে আমরা ইয়েতে যাই, বর্ণনায় যাই, বর্ণনার মধ্যে আপনি আসলে খুব সুন্দর করে লিখে দিয়েছেন।
এই যে দেখেন,
আরেক সরি, এই যে এই জিনিসটা সবার আগে আমি জোর দিচ্ছি। দেখেন ওই যে রফিক স্যার আমাদের কাছে দুটো জিনিস শেখাইছেন। এক নম্বর হলো সিস্টেম হতে ফলো করে, শুধু ডায়াগনোসিস হারি করে যেও না। 2 নম্বর শিখাইছেন হ্যাভ ডিফারেন্স অফ অপিনিয়ন, মাল্টিপল অপিনিয়ন, সেটা কোনো আপত্তি নেই। এখানে আমরা রেটটা দেখতে পাচ্ছি, রিদম সাইনাস কিউরিস নরমাল সবই দেখছি, কিউ দেখলাম। এরপরে লিখছি ST2 of changes, minimal ST elevation in V1 to V3, preserve outward progression with biphasic tubet, diagnosis Wellens syndrome. কেন সেটা বলা হচ্ছে। আবার ইসিতে ব্যাক করেন, ইসিজিতে ব্যাক করেন।
হ্যাঁ ইসিজি
স্লাইড
দেখতে পাচ্ছেন ইসিজি।
হ্যাঁ, এখানে দেখেন বলা আছে 56 year old man ডায়াবেটিক, বয়স মেল পারসন ডায়াবেটিক, অলরেডি রিস্ক ফ্যাক্টর আছে। ECG chart of admission is CCU, admitted with 15 hours of history of central chest pain with minimal exertion. BP normal, signs of heart failure 9, slightly elevated cardiac troponin, but এটাকে ঠিক ST elevated MI বলা যাচ্ছে না। টিপিক্যাল যে কোভিড যেটা সেটা নাই, এটা ST elevation আছে বাট ওরকম না, কিন্তু দ্য টি ওয়েভটা ডিস্টিংক্টলি বাইফেজিক। এটা হলো ওয়েলেন্স সিনড্রোমের বৈশিষ্ট্য। এখন আমরা উত্তরে যাই আবার একটু, উত্তরে পরের স্লাইডটা আবার,
হ্যাঁ দেখা যায় না,
পরের স্লাইড। হ্যাঁ এই দেখেন রিসেন্ট এনজাইনা আছে, নরমাল স্লাইট এলিভেটেড কার্ডিয়াক মার্কার, আইসোইলেকট্রিক অর মিনিমাল ST এলিভেশন, ডিপলি ইনভার্টেড হয় অথবা বাইফেজিক টি হয়। ডিপলি ইনভার্টেড বেশিরভাগ ক্ষেত্রে, বাইফেজিক টিটা বেশি ক্লাসিক্যাল, সেটা মাত্র 25% ক্ষেত্রে। সবচেয়ে বেশি ইম্পর্টেন্ট হলো দিস ইজ হাইলি স্পেসিফিক ফর ক্রিটিক্যাল স্টেনোসিস ফর প্রক্সিমাল এলিটি। দিস ইজ অ্যাকিউট করোনারি সিনড্রোম বাট নট ST এলিভেটেড MI, এবং এটা হলো ইন্ডিকেশন দ্যাট এই পেশেন্টকে খুব আর্লি আমরা ক্যাথল্যাবে নিয়ে যাওয়া উচিত, না হলে দিস পেশেন্ট মে ডেভেলপ ইনটু এক্সটেন্সিভ এন্ট্রোএমআই অর কার্ডিয়াক অ্যারেস্ট। দ্যাটস দ্য মোস্ট ইম্পর্টেন্ট থিং। একে আমি আর্লি ইনভেসিভ নেওয়ার জন্য অ্যাগ্রেসিভ ট্রিটমেন্ট করতে হবে, করে তাকে আমাকে আর্লি ক্যাথল্যাবে নিয়ে যেতে হবে। এটা সবচেয়ে ইম্পর্টেন্ট জিনিস।
এটা স্যার টাইপ এ অর টাইপ বি?
এটা হলো তোমার বাইফেজিক হলো এ টাইপ এটা, আর ডিপ ইনভার্টে হলো টাইপ বি। এটা কিন্তু বাইফেজিক। বাইফেজিকটা ক্লাসিক্যাল বর্ণনা ছিল, কিন্তু ওটা হলো 25% ক্ষেত্রে। বেশিরভাগ ক্ষেত্রে আমরা ডিপলি ইনভার্টেড টি ওয়েভ পাই, সিমেট্রিক্যাল টি ডিপলি ইনভার্সন পাই, বড় বড় টি ইনভার্সন। But that also in the similar background with preservation of R wave that goes in favor of Wellens syndrome, proximal LAD, critical stenosis, acute coronary syndrome.
আচ্ছা তাহলে এটা বন্ধ করি।
রফিক স্যার আপনার লেকচার স্যার খুব সুন্দর লেকচার হয়েছে স্যার, আপনি আর কিছু বলতেন আমাদের উদ্দেশ্যে?
থ্যাংক ইউ। না থ্যাংক ইউ, ভালো লাগে। আই এনজয় ডুইং দিস, ইট কিপস মাই ব্রেইন ফ্রেশ, ইট কিপস মি ফ্রম গেটিং ওল্ড। থ্যাংক ইউ।
পার্টিসিপেন্ট সবাইকে বলছি, রফিক স্যার আমাদেরকে সবাইকে বলতে মানে যেটা শিখিয়েছেন যে ইন্টেলেকচুয়াল ডিবেটে ফেরত শাস্তি ডিবেট করো, কোনো আপত্তি নাই, বাট এট দ্য এন্ড অফ ডিবেট সবাই একসাথে মিলে মিষ্টি খেতে চলে যাও।
আচ্ছা আমার মনে
স্যারের যে অ্যাটিটিউডটা, আমরা কিন্তু তার ফলোয়ার।
আচ্ছা বিফোর কনক্লুডিং, আচ্ছা আমার মনে যে পাচ্ছিলাম না, বাট মাহবুবুর রহমান বাবু স্যার উনি ইন্টারেস্ট নিয়ে আমাদের প্রত্যেকটা প্রোগ্রামে থাকেন। বাবু শুনতে পাচ্ছেন?
স্যার আসসালামু আলাইকুম, থ্যাংক ইউ স্যার। রফিক স্যার জানেন স্যার আমার একদম বুকের মধ্যে একটা স্যার, উনি আমাদের টিচারের টিচার। স্যারের প্রত্যেকটা লেকচার আসলে প্রত্যেকটা ফেলোর জন্য খুব হেল্পফুল হচ্ছে, এবং আমি জানি পরীক্ষাতে তারা এত ইজি হয়ে যাবে ইসিজি গুলা, এবং এই যে আজকে যেগুলা স্যার আলোচনা করলেন যে এগুলো খুবই হেল্পফুল হবে। এবং এই শাহাবুদ্দিন স্যার শুধু না, আমাদের ওয়াদুদ স্যার সহ আতার স্যাররাও স্টুডেন্টদের একদম বুকের ভিতরে ঢুকে গেছে। এই বিশেষ করে এই আমি বলবো এই করোনাকালীন টাইমটাতে ওয়েবিনারে তারা ভাবে নাই যে এই 5 মাস তারা এত সুন্দর করে ক্লাস করে তারা তাদের লেখাপড়াটা কন্টিনিউ করতে পারছে। এই জন্য রফিক স্যার সহ আমি যারা এই অর্গানাইজার, আমি সবাইকে ধন্যবাদ জানাই। আমি শুধু স্যার এটার সাথে একটু সাজেশন দিই যে পোস্টারটা যে করেছেন, পোস্টারটাতে 2 জন ইউএসএ রফিক স্যার এবং আমাদের ওই ডক্টর সাহেব 2 জন ইউএসএ লেখা আছে। এটা যদি আমাদের যারা আছেন আপনারা 3 জন, আপনি ওয়াদুদ স্যার, আতার স্যার, তুষার, তাদের নামের নিচেও যদি বাংলাদেশটা থাকতো, আমার মনে হয় এটা ওয়ার্ল্ড ওয়াইড অনেকেই দেখবে এই পোস্টারটা, নট অনলি বাংলাদেশ, এটা নেপাল এবং ইউএসএ সব দেশে দেখবে। তো মানে আপনারা যে আমাদের দেশের প্রতিনিধি, এই জিনিসটা তাহলে একটু হাইলাইটেড হবে। এটা আমার একটা ছোট সাজেশন যে পোস্টারটাই যদি কারেকশন করে একটু যারা বাংলাদেশ থেকে করছেন যে নিচের বাংলাদেশ যদি লিখে, যদিও ওয়াদুদ স্যারের ঢাকা মেডিকেলে ঢাকা লেখা আছে, কিন্তু ঢাকা বাংলাদেশটা লিখলে আমার মনে হয় যে পোস্টারটা আরো অনেক সুন্দর হবে। ধন্যবাদ রফিক স্যার, আপনাকে অনেক ধন্যবাদ সবাই স্যার।
থ্যাংক ইউ ভেরি মাচ। আমার মনে ওয়াদুদ ভাই
আপনি কন্ট্রোল করে দেন। আর বেক্সিমকোকে অসংখ্য ধন্যবাদ, তারা এটা আমাদের সাথে আছে। মজুমদার স্যার সব সময় দেখি এইরকম এই প্রোগ্রামগুলো স্যার যদি খেয়াল করে দেই কখনো মিস করেন না।
একটু কমেন্ট আছে স্যার আমার, যদি
ভাই গোবিন্দ ময়মনসিংহের প্রতিনিধি আমাদের।
very much we have learned a lot from your talk regarding basic mechanism of arrhythmia and also ECG. আমাদের ময়মনসিংহে কিন্তু স্যার ক্যাথ ল্যাব চালু হয়েছে আর কি, বসানো মেশিন বসানো হয়েছে, এখনো মানে শুরু হয়নি স্যার আর কি। আপনি অনেকবার ই করছিলেন আর কি, এসে দেখে গেছেন, বলে গেছেন যে কিভাবে কি করা যায়। অনেক এখন অলরেডি আমরা এটা ই করতে পারছি আর কি, গভর্নমেন্ট থেকে দেওয়া হয়েছে ঠিকভাবে। এখন করোনা শেষ হয়ে গেলে হয়তো শুরু করা যাবে আর কি, আপনি যখন আসবেন তখন আর কি। আপনি কি জানেন স্যার এটা যে ক্যাথ ল্যাব বসানো হয়েছে স্যার?
শুনছি আমি, জি শুনছিলাম।
আমার আপনি অনেকবারই বলছেন। তো ধন্যবাদ স্যার, অসংখ্য ধন্যবাদ স্যার আপনাকে, সবাইকে ধন্যবাদ। আসসালামু আলাইকুম
স্যার। আমার মনে হয় যে আজকের লেকচার আমরা যেমনটি চাইছিলাম, আমাদের স্যার প্রায় মানে আমাদের এই জুমে এবং প্রায় ফেসবুক মিলে মোর দ্যান 400 পার্টিসিপেন্ট ছিল, এবং আমার মনে হয় যে এভরিবডি এনজয়েড ইউর লেকচার। এবং আমার মনে হয় যে স্যার বিশেষ আমাদের এমনি এই ইসিজি প্রোগ্রাম তো পছন্দ করেই, তার উপরে বিশেষ করে যখন আপনার কথা শুনে তখন আরো বেশি এটা ইন্টারেস্ট ফিল করে। এবং আমি আমার এই প্রোগ্রামে সার্বক্ষণিক আমার মনে হয় যে ধৈর্য ধরে আমাদের যে প্রফেসর মজুমদার স্যার, তারপরে প্রফেসর শাহাবুদ্দিন, এমজি আজম, আমাদের আব্দুল্লাহ
ছিলেন, নজরুল স্যারকে পড়ে পেলাম না,
নজরুল স্যারও ছিলেন আর কি, আমাদের প্রফেসর জাকির, প্রত্যেকে অত্যন্ত বিজি। তারপরে মিশকাত আহমেদ চৌধুরী, রিয়েলি স্যার আমরা ওনাদের কাছে খুবই গ্রেটফুল, কারণ ওনারা থাকলে আমরা আরো বেশি ইন্সপায়ার্ড হই আর কি, মানে চিন্তাই করা যায় না। তো আমার মনে হয় যে আমরা প্রত্যেককেই থ্যাঙ্কস জানাচ্ছি। এবং আবার আমাদের সামনে প্রোগ্রাম এবং আমাদের আগামী শনিবার দিনের প্রোগ্রাম, আমাদের প্রত্যেক দিনই রফিক স্যারের কিন্তু সেশন থাকে স্যার, এভরিডে। রফিক স্যারের মেইন টক থাকুক বা না থাকুক, এভরিডে দেয়ার ইজ সেশন অফ দ্য রফিক স্যার। সুতরাং আমরা প্রত্যেকে আবার অনুরোধ করবো যে আমাদের এই প্রোগ্রামে পার্টিসিপেট করার জন্য। আজকে সবাইকে পার্টিসিপেট করার জন্য মেনি থ্যাঙ্কস এভরিবডি। এবং আমাদের নেক্সট প্রোগ্রামটা আগামী শনিবার দিন, আর 11 তারিখের কথাটা মনে করে দিলাম।
11 তারিখ প্রোগ্রামে বেক্সিমকোর সাথে আমাদের অ্যাবোর্ড সিআর তারাও কিন্তু আমাদেরকে হেল্প করছে।
আর তারেক, তোমাকে আরো একবার বলি, আমার যে রফিক স্যারের যে লিংকটা পাঠাও, স্যারকে কিন্তু এর আগেও স্যার ফেস করেছে, এবারে করছে, স্যারকে কিন্তু ফ্যাকাল্টি হিসেবে পাঠাও, নট পার্টিসিপেন্ট হিসেবে। আজকে স্যারের দেরি হয়েছে কিন্তু এই কারণে।
জি স্যার।
থ্যাংক ইউ।
আতার ভাই, ওই শনিবারের প্রোগ্রামটা বেক্সিমকো ফার্মার সাথে অ্যাবোটো আমাদেরকে হেল্প করছেন দেশমুখের ব্যাপারে, রফিক স্যার তো আমাদের, আর দেশমুখকে নিয়ে আসার ব্যাপারে ওরা হেল্প করছে, এটা আমরা অ্যাকনোলেজ করি।
হ্যাঁ অবশ্যই অবশ্যই, ডেফিনেটলি। হ্যাঁ
থ্যাংক ইউ
স্যার।
আসসালামু আলাইকুম।
রফিক ভাই, আসসালামু আলাইকুম।
আসসালামু আলাইকুম স্যার।